Dear students, a very warm welcome to all of you in this program of developmental biology. Today we are going to learn about an important aspect of implications of developmental biology in terms of teratogenesis. Let us start with the introduction of teratology first. Teratology is the study of formation of congenital anomalies in developing embryo or fetus, which may lead to birth defects or even death. Teratogenesis can be defined as formation of congenital defects due to exposure to teratogens. The word teratogen originates from the Greek word used for monster or marvel to describe malformed infants called teratos. The term teratogen is cited in the context of the agent responsible for producing certain anatomical defects in an embryo that was previously differentiating normally. More precisely, teratogens are biological, chemical or physical substances that may produce physical or functional defects in the developing embryo or fetus after the exposure of pregnant woman to them. Nowadays, birth defects are the leading cause of infant mortality in the world, which accounts for approximately 20% of the total infant mortality observed. Of these defects, about 20 to 25% are of genetic origin and 65 to 75% are of unknown etiology. That is, multifactorial, polygenic, spontaneous errors of development and synergetic interactions of teratogens. Out of this 65 to 75%, approximately more than 5% of the birth defects are the result of exposure to various teratogens. Adverse effects of teratogens are normally associated with physical malformations. About 2% of human infants are born with a readily observable anatomical abnormality. Apart from this, problems in the behavioral or emotional development of the child as well as decreased intellectual quotient in the child are also encountered. Additionally, teratogens may also affect pregnancies and cause complications such as preterm labors, spontaneous abortions or miscarriages. In terms of mechanism of cellular action, a teratogen may potentially affect embryogenesis by causing gene mutation, chromosomal breakage, non-disjunction, depletion or inhibition of precursors or substances, depletion of energy sources, inhibition of enzymes or changes in membrane integrity. These effects may lead to cell death, reduced cell division, reduced interaction between cells, disruption of cell migration or mechanical disruption with the ultimate result of failure in the particular organ system development. Now, let us know about certain essential principles of teratology one by one. The first principle states that teratogens act with specificity and produce specific abnormalities at specific developmental stage during gestation. For example, thalidomide produces limb phocomelia while valproic acid and carbamazepine produce neural tube defects. The second principle implies that the effect of a teratogen on the developing organism depends on critical period during pregnancy in which the embryo or fetus is exposed to the teratogen. Some teratogens cause damage only during specific days or weeks in the early pregnancy. Other teratogens are harmful at any time during the pregnancy. For example, for behavioral teratogens, there is no safe period because the brain and nervous system can be harmed throughout the pregnancy. According to the third principle, teratogenic specificity is also applied to species. For example, aspirin and corticosteroids have been found to be teratogenic in mice and rats but appear to be safe in humans. On the other hand, thalidomide produces phocomelia in primates but not in the rodents. Within a given species also, a given teratogen may affect many organ systems. For example, administering thalidomide between days 35 and 37 causes ear malformations, while administration of the agent between days 41 and 44 causes phocomelia. As per the fourth principle, teratogens are found to be associated with recognizable pattern of the malformations. For example, phenytoin with the fetal hydantoin syndrome and coumarin anticoagulants with the fetal warfarin syndrome. The fifth principle implies that teratogens generally demonstrate a dose-effect relationship ranging from no observable effects to total lethality. At any given time, an embryo can respond to a teratogen in one of the three ways. First, at low dosage, there can be no effect. Second, at intermediate dose, the characteristic pattern of malformations will result. And third, at high dosage, the embryo will be killed. According to the sixth principle, teratogens must reach the developing conceptors in sufficient amount to cause their effects. Large molecules with the higher molecular weights do not easily cross the placenta into the embryonic fetal bloodstream to exert potential teratogenic effect. Other factors influencing the rate and extent of placental transfer of xenobiotics include polarity, lipid solubility, and the existence of a specific protein carrier. The seventh principle explains that teratogens act via a specific mechanism on developing cells and tissues to initiate a cascade of altered developmental events. The next principle states that teratogenic effects are dependent on the nature of the teratogen, including chemical properties of the substance, route of exposure, maternal or fetal bioactivation, placental transport, etc. As per the modern refined principles of the teratology, teratogens produce a consistent deviation from the normal development. Deviation may include death, malformation, growth retardation, or functional defect. The last principle states that the genotype, that is, genetic makeup of the mother and the fetus, determines the efficacy of a teratogen. Presence or absence of certain genes may make the developing organism more susceptible to the effect of a teratogen. Variability in teratogenic response is also found to be associated with other environmental or morphogenic factors such as maternal or fetal weight, in utero position of the fetus, uterine vasculature, diet as well as drug interactions. Causes of teratogenesis. Let's see how and why the things go wrong during embryological development. A particular birth defect may be the outcome of action of many different factors as well as various mechanisms. The major causes of teratogenesis can broadly be classified as exposure to toxic substances such as drugs and environmental toxins during pregnancy in humans, vertically transmitted infections, lack of nutrients such as deficiency of folic acid in the nutrition during pregnancy for the humans can result in defect called spina bifida, physical restraint like Potter syndrome due to oligohydramnios in the human, and genetic disorders. In addition, maternal determinants including drug administration, distribution, metabolism and excretion may also play an important role in teratogenesis. Classification of teratogens. Dear students, let us move on to the essential part of this lecture by obtaining detailed information about classification of teratogens. Teratogens are classified into four types: physical agents, infectious agents, maternal metabolic conditions, and finally chemicals as well as drugs. Let's get an overview of the first type of teratogens as physical agents in terms of ionizing radiation. High dose of ionizing radiation over a short period of time leads to abnormal brain development, mental retardation, and leukemia in children. The common anomalies include small head circumference called microcephaly and small eyes known as microphthalmia. Even a single computer tomography scan employed as a tool of diagnosis creates a radiation exposure dose that equals to tens of X-rays and should be avoided during pregnancy. The second type of teratogens includes various infectious agents such as protozoa, bacteria and viruses. Let's begin with Toxoplasma. Toxoplasma is a single-celled parasitic protozoan. The Toxoplasma infection is often obtained by eating contaminated meat, drinking contaminated water, or coming into contact with infected cat feces. Toxoplasma infection during pregnancy can be extremely dangerous to the baby. It can lead to spontaneous abortion or delivery of the dead infant, or the baby might have underdevelopment of the brain calcifications, blindness, and seizures. Now, let us see adverse effects of infection caused by syphilis bacteria. Syphilis is a sexually transmitted bacterial disease caused by Treponema pallidum. If a pregnant woman has syphilis and is not treated quickly, then this tiny bacteria travel with her blood to the baby's body. Syphilis infection can cause a fetal death and spontaneous abortion, or can result in the delivery of the dead baby, or the baby can die within several days of life. If the baby survives, there is a high risk that this baby will have copious nasal discharge packed with the treponemes and severe inflammatory reactions as a consequence, destroying the nasal cartilages and bones. The baby will likely suffer from liver and spleen enlargement and dysfunction, meningitis, and inflammatory skin rash as a part of symptoms of early congenital syphilis. Some babies will demonstrate symptoms of late congenital syphilis around the 8 years of the age. Their vision will become deteriorated due to inflammatory changes in the eyes. Some of their central permanent teeth will have unusual conic shape and notching, and they may become deaf with complaining of vertigo and ringing in the ears. Their bones will be deformed, resulting in the look of saddle nose and saber sheens. The third type of infectious agent is viruses. Viruses are incredibly small live particles composed of DNA or RNA requiring the host cells for replication. Certain types of viruses are well known to create birth defects. Rubella or the German measles virus exposure to the fetus can be culprit of congenital heart defects, deafness, and blindness. Rubella virus can also be a cause of abnormal brain development and other internal organs and creates characteristic bluish red skin lesions known as blueberry muffin spots. Cytomegalovirus CMV infection is the most ubiquitous type of fetal infection. CMV can be a cause of mental retardation, cerebral calcification, intrauterine growth retardation, blindness, deafness, dysfunction of the liver and the spleen, jaundice or lesions on the skin known as blueberry muffin spots. Infection of the early embryo during the first trimester most commonly results in the spontaneous termination. Herpes virus infection in about 5% cases can affect baby in the uterus. The consequences are catastrophic, from fetal death to the permanent problems like underdevelopment and or calcification of the brain, blindness or abnormal limb formation. If the herpes virus was acquired by the baby during or just after the delivery, the baby will get herpetic pneumonia or meningoencephalitis. Varicella zoster virus is a cause of chickenpox mostly in children and herpes zoster mostly in seniors. If a pregnant woman would possess varicella zoster virus for the first time during the pregnancy, there is 25 to 40% risk that the fetus will have underdeveloped limbs, brain or eye malformations and specific zigzag skin scarring. Infant can also suffer from severe varicella zoster pneumonia. Now, let us learn in detail about the third type of teratogens as maternal metabolic conditions. The first maternal metabolic condition is diabetes mellitus. Hyperglycemia can be considered as the key in pathogenesis of diabetes embryopathy. The gastrulation and neurulation stages of the development are particularly sensitive to the hypoglycemia and result in the growth retardation as well as cranial and caudal neural tube defects and TDs. The second metabolic condition is obesity. During pregnancy, obesity is associated with adverse outcomes that include hypertension, gestational diabetes mellitus, increased risk of birth defects and fetal death. The third maternal condition is presence of thyroid disorders. They include disorders in which the thyroid gland malfunctions, thereby producing abnormal amounts of the thyroid hormones thyroxine and triiodothyronine, which regulate the metabolism. Thyroid disorders can cause number of teratogenic effects to a developing fetus as well as adverse effects on the pregnancy such as miscarriage, premature separation of the placenta from the uterine wall called placental abruption, preterm labor and low IQ scores in the children. It leads to hypothyroidism or hyperthyroidism in fetus. Hypothyroidism occurs when the fetal thyroid glands have been suppressed by antithyroid drugs like propylthiouracil, carbimazole, radioactive iodine or possibly maternal antibodies. Hyperthyroidism occurs in the presence of thyroid stimulating globulins, which may result in thyrotoxicity in the fetus and newborn. Affected infants have goiter, exophthalmos, restlessness, tachycardia, ravenous appetite, hypothermia, cardiomegaly, cardiac failure and hepatosplenomegaly. Hyperparathyroidism is the fourth metabolic condition. Infants of the mothers with the parathyroid dysfunction may have transient hyperparathyroidism during the fetal and neonatal periods. It occurs in response to low maternal and fetal serum calcium concentration mediated by maternal parathyroid dysfunction, which results in intrauterine growth retardation, pulmonary artery stenosis and muscle hypotonia. Cretinism and iodine deficiency accounts for next maternal condition. Iodine deficiency is the cause of endemic goiter and cretinism due to deficiency or insufficient availability of thyroxine at the fetoplacental level. In early pregnancy, iodine deficiency induces critical decrease of T4 levels with the consequent TSH increase, leading to hypothyroidism in about 50% of iodine deficient pregnant women. Myotonic dystrophy also acts as one of the maternal metabolic conditions. Infants born of women with the myotonic dystrophy may show fetal hypokinesia and generalized weakness and may experience difficulty in respiration as well as feeding. The face characteristically shows tenting of the upper lip, ptosis, absence of movement and anterior cupping of the pinnas with presence of clubfoot and slow postnatal growth. The next metabolic condition includes phenylketonuria. Maternal phenylketonuria (PKU) induced defects are directly related to the maternal phenylalanine level. When the level exceeds 20 mg per ml, infants suffer from mental retardation, microcephaly, intrauterine and postnatal growth retardation, cardiac malformations, dislocated hips and other anomalies. 1/4 of the pregnancies abort spontaneously due to this reason. The last type of maternal metabolic condition is referred to as thermodisruptions. It can be categorized by hypothermia or hypothermia. Hypothermia is defined as body's temperature of at least 38.9 degrees centigrade and is an anti-mitotic teratogen after exposure between weeks 4 and 14. Hyperthermia causes central nervous system malformations, abdominal wall defects, defects of the eye and palate, limb reduction, neural tube defects, mental deficiency, seizures, spontaneous abortions and various cardiovascular abnormalities. Hypothermia is defined as a core body temperature of less than 35 degrees centigrade. Infant with the multiple congenital defects, severe disruptive effects of the brain and distal spinal cord may be observed due to hypothermia. The fourth type of teratogens in the classification comprise of chemicals and drugs. Let us first understand the chemicals as teratogens with appropriate examples. First, mercury. Organic mercury like methyl mercury compounds can be extremely dangerous for the developing fetus in a small dose. Organic mercury exposure can lead to atrophy of the granular layer of the cerebellum and damage to neural system, mental retardation, behavioral and cognitive problems as well as blindness in a baby. Second, lead. A woman with the lead poisoning can pass lead onto her fetus if she becomes pregnant. This happens because more than 90% of the lead may be stored in bone and released into the bloodstream years later. Lead crosses the placenta as early as 12th and 14th week of the gestation and accumulates in the fetal tissue. The adverse effects of the lead include spontaneous abortion, abnormal and delayed mental or physical development of the child, and stillbirth. The vectoral, that is vertebral, anal, cardiac, tracheoesophageal fistula, renal and lip abnormalities association has been reported with prenatal exposure to high lead levels. Third, potassium iodine. Large doses of the potassium iodine found in anti-cough syrup or medical cocktails for the X-ray diagnostic can be a cause of abnormal thyroid development and function in a fetus. This effect will lead to mental retardation or cretinism in a child. The fourth type is the polychlorinated biphenyls. PCBs were linked to the delayed fetal growth, abnormal neural system development and impaired behavioral and cognitive functions in a child. Fifth one is the alcohol. Alcohol can cross the placenta and affect the fetus. Excessive maternal drinking while pregnancy can cause fetal alcohol spectrum disorder (FASD). Physically, children with the FASD may have small head size, abnormal facial features such as small eyes and nose, thin upper lip, ear abnormalities, small nose, cleft palate and cardiac anomalies. Cognitively, these children may have poor judgment, learning difficulties, behavioral problems and mental retardation. Sixth one is the cigarette smoking. Cigarette smoking women have higher risk of miscarriage, stillbirth, low birth weight, premature birth, sudden infant death syndrome called SIDs, possibly increase in the developmental delays and infant with the cleft palate. Seventh is cocaine. Cocaine use during pregnancy has been associated with the detachment of the placenta, prematurity, fetal loss, decreased birth weight, microcephaly, limb abnormalities, urinary tract malformations and poorer neurodevelopmental performance. Now, let's quickly get an overview of the proved teratogenic drugs in humans. First one is the thalidomide. More than any other event, the thalidomide tragedy alerted the world maximum to the teratogenic potential of the drugs. A new era of teratology was initiated as a result of clinical use of thalidomide by pregnant women for the relief of morning sickness. Thalidomide was marketed in the year 1956 and was available for 4 years before its teratogenicity was recognized. Thalidomide produced malformations limited to the tissues of mesodermal origin, primarily limbs, ears, cardiovascular system and gut musculature. Malformations resulted from the repeated use as well as from the single injections during the critical period from 27th to 40th day of the gestation. Numbers of cases of phocomelia were reported due to thalidomide teratogenicity, which is characterized by rare type of the congenital malformation with the shortening or the total absence of limbs. Typically, the upper limbs were more severely involved than the lower limbs. Polydactyly, syndactyly, oligodactyly were also reported in certain cases. The second type of the drug is the angiotensin converting enzyme inhibitors ACEI, that is captopril, enalapril, lisinopril. ACEI are potent anti-hypertensive drugs. Their use in the late pregnancy has been associated with fetal toxicity including intrauterine renal insufficiency. Reports of neonatal hypotension, oliguria with the renal failure and hyperkalemia have been reported with ACEI use in pregnancy. Complications of the oligohydramnions, that is fetal limb contractures, lung hyperplasia and craniofacial anomalies, prematurity, intrauterine growth retardation and fetal death have also been reported with the use of these agents in late pregnancy. Third drug is the carbamazepine. Exposure to carbamazepine in utero carries 1% risk of neural tube defects. A pattern of malformations similar to those described with the fetal Hayden-Toyne syndrome has also been associated with the carbamazepine exposure in pregnancy. Fourth is the coumarin anticoagulants. First trimester exposure to coumarin derivatives is associated with a characteristic pattern of malformations termed as the fetal warfarin syndrome. Clinical features consist of nasal hyperplasia and calcific stippling of the epiphysis, intrauterine growth retardation, development delay due to central nervous system damage, as well as hemorrhage, eye defects and hearing loss. The critical period of the exposure for the fetal warfarin syndrome appears to be between 6th and 9th weeks of gestation. Oral anticoagulants readily cross the placental barrier and associated with high rate of miscarriage. Fifth is the diethyl stilbestrol. Diethyl stilbestrol was used in 1950s and 1960s for the diagnosis of the recurrent miscarriage. Clear cell adenocarcinoma type of cancer of the vagina was found to be associated with diethyl stilbestrol treatment of the patient's mother during the first trimester of pregnancy. Sixth drug is the folic acid antagonist like aminopterin and methotrexate. Aminopterin has been known since 1950 to result in the fetal death, which led to its use as human abortifacient. Malformations include central nervous system defects, facial anomalies such as cleft palate, high arched palate, ocular hypertelorism, abnormal cranial ossification, abnormalities in the first branchial arc derivatives, intrauterine growth retardation and mental retardation. Infants have born with the features of the aminopterin syndrome after pregnancy due to methotrexate exposure. Seventh drug is the Hayden-Toynes such as phenytoin and trimethadione. Hayden-Toynes have been associated with a recognizable pattern of the malformation termed as fetal Hayden-Toyne syndrome. The clinical features include craniofacial dysmorphology, that is ocular hypertelorism, metopic ridge, broad depressed nasal bridge, short anteverted nose, bowed upper lip, cleft palate, hyperplasia of the distal phalanges and nail hyperplasia. Growth retardation, mental deficiency and cardiac defects are additional features of the syndrome. Eighth drug is the misoprostol. Misoprostol is a synthetic prostaglandin E1 analog prescribed for duodenal and gastric ulceration, also used as an abortifacient by the woman in Brazil. The association between first trimester exposure to the misoprostol and limb defects with or without Mobius sequence has established to certain extent. Ninth is the antibiotics. Aminoglycosides antibiotics exhibit 2% increased risk for hearing impairment. Tetracycline and doxycycline can cause yellow-brown staining of the teeth when used during 4th to 9th month of pregnancy timing, when the deciduous teeth begin to calcify. If this medication is used in the 3rd trimester, there can be decreased fetal bone growth. 10th one is the valproate. First trimester exposure to the valproate is associated with neural tube defects and carries 1 to 2% risk of the meningomyelocele, primarily lumbar or the lumbosacral. An associated pattern of malformation is termed as the fetal valproate syndrome. The clinical features include narrow bifrontal diameter, high forehead, epicanthal folds, infraorbital creases, low nasal bridge, midfacial hyperplasia, long philtrum, small mouth, cardiovascular defects, long fingers and toes, hyperconvex fingernails and cleft lip. 11th drug is lithium. It is used in the treatment of the bipolar disorder. If possible, lithium should be withheld during the first trimester of the pregnancy. Cardiovascular malformations in the particular abstain anomaly and tricuspid atresia have been related to lithium exposure. Infants exposed in utero to lithium may experience transient lethargy, cyanosis, poor feeding and poor respiratory efforts during the early neonatal period. Other defects that have been noted in infants exposed to lithium in utero include malformations of the central nervous system, ear and ureter, altered thyroid and cardiac function as well as congenital goiter. 12th drug is the isotriotinoin, that is 13-cis-retinoic acid. Isotriotinoin is a synthetic vitamin A derivative prescribed for severe cystic acne that has been proved to be a potent human teratogen as well as behavioral teratogen when given systemically. The clinical features include craniofacial anomalies such as narrow sloping forehead, micrognathia, flat nasal bridge, cleft lip, cleft palate and ocular hypertelorism. Cardiac defects and alterations in the central nervous system development also observed. Risk for associated miscarriage were also found to be approximately 40%. The 13th drug is Accutane. Accutane is retinoic acid that is prescribed for treatment of severe acne. This medication is extremely dangerous as infants exposed in the first trimester will exhibit abnormalities like hydrocephalus, that is excess fluid in the brain, brain defects, mental retardation, ear or face abnormalities, heart and limb defects and chronic skin lesions. There is also an increased risk of miscarriage. There are also certain drugs having possible teratogenic potential in the humans, which include first D-penicillamine. High dose treatment of the pregnant woman with the D-penicillamine has been found to be associated with connective tissue disorder referred to as cutis laxa. Second is the methimazole. Methimazole treatment during pregnancy has been associated with the scalp defects known as aplasia cutis congenital. The third drug is the diazepam. First trimester exposure to diazepam can lead to small increase in the incidence of the cleft lip and palate. Fourth one is the antidepressants. With the antidepressants, the baby may tend to be more irritable and have problems in feeding. There can also be premature delivery. Now, let us understand the effects of teratogens on the embryonic and fetal development in detail. The time during embryogenesis when the fetus is exposed to a potential teratogen is very crucial. The effect produced by teratogen depends upon the developmental stage in which the fetus is exposed to it. 3 stages of susceptibility may be identified, with these times varying from one organ system to the another. The first stage is pre-differentiation stage. The time from the conception until implantation is known as all or none period. The embryo is relatively resistant to teratogenic insults during the first few weeks of life, perhaps 2 weeks after conception in humans. During this stage, large insults to the embryo are likely to result in the death of the conceptors and miscarriage or in intact survival. Presumably, the explanation is that at this stage the embryo is undifferentiated and repair as well as recovery is possible through multiplication of the still totipotent cells to replace those which have been lost. If one cell is destroyed, a surviving cell may compensate and able to assume its function to form normal embryo. Therefore, exposure of the embryos to teratogens during the pre-implantation stage usually does not cause congenital malformations. The second stage is referred to as embryonic stage. The embryonic period from 18th to 60 days after conception is the period of organogenesis. That is, the process of organ differentiation occurs in most human organ systems between embryonic weeks 3 to 8. This is the period of maximum sensitivity to the teratogens, since not only are tissues differentiating rapidly, but damage to them becomes irreparable. Exposure to teratogenic agents during this period has the greatest likelihood of causing structural anomaly. Teratogens act in an organ-specific fashion. A teratogen may affect one organ system at one stage of development but another system at another stage. The pattern of the anomalies produced depends upon which systems are differentiating at the time of teratogenic exposure. For example, development of the brain and gonads continues in the second and third trimesters of pregnancy. Therefore, drug use at this time in pregnancy is a concern. Some of the uterine anomalies resulting from diethylstilbestrol occurred with exposure as late as 20 weeks but were not recognized until after puberty. The third stage is the final fetal stage. The fetal phase from the end of the embryonic stage to term is the period when growth and functional maturation of the organs and systems already formed occurs. Teratogen exposure in this period will affect fetal growth. For example, intrauterine growth retardation, the size of a specific organ or the function of the organ rather than cause gross structural anomalies. Of particular interest is the potential effect of the psychoactive drugs such as antidepressants, anti-epileptics, alcohol and other drugs of the abuse on the developing central nervous system, which has led to a new field of the behavioral teratology. Recent findings of the teratology suggest that the classification of a drug as A, B, C, D or X provides a guideline to expecting mother for making determinations about using drugs during pregnancy. For example, class A drugs are deemed always safe, whereas class X drugs have proven to be damaging to the fetus and teratogenic in nature. Now, let us quickly summarize today's lecture. In this program of developmental biology, we have learned about teratogenesis as an essential element of implications of embryology. Initially, we have gained the information about different terminologies related to teratology. We have also learned various principles of teratogenesis one by one. Along with this, we have also got an overview of different causes of teratogenesis. Not only this, we have also focused on the classification of 4 different types of teratogens as physical agents, infectious agents, maternal metabolic conditions and various chemicals as well as drugs, along with appropriate examples including malformations induced by them. At last, we have acquired detailed understanding of different stages of embryonic and fetal development and effects of teratogens on them. Hope this lecture will provide adequate knowledge to people in the world about teratogens and their serious health effects and in turn help in spreading awareness about avoiding their adverse exposure. Thank you very much.